is a surgical anatomy of stomach. Now, most of the students already know about the stomach anatomy. Now, look at this picture, very simple picture. Stomach is a dilated part of our GI tract. Okay, see there, this is the shape of the stomach. So here is the esophagus, which is continuous with the stomach. And stomach is present in the epigastric region mainly. So this is the lower end of the esophagus, which is connected to the cardiac end of the stomach. This is called fundic part of the stomach or fundus of the stomach. The main part is called body of the stomach, and the terminal part is called pylorus of the stomach, okay, which is connected with duodenum or first part of the duodenum through pyloric sphincter. Pyloric sphincter is present right here. So this area is called pylorus. It has got different parts, sphincter and antrum. This is called pyloric antrum, okay, and the lower part is called pyloric sphincter. Now, stomach has greater curvature. This is called greater curvature, and here is lesser curvature. See there, okay. This is cardiac end. This is pyloric end. So these are different parts of the stomach. Now see this. The stomach is J-shaped hollow part of the alimentary tract, situated just below the diaphragm on the left side in the abdominal cavity. Basically, it is present in the epigastric region. That area is called epigastrium. These are the parts: fundus, body, and the pyloric part. It has got pyloric antrum and pylorus or pyloric sphincter. Now there are two orifices: cardiac orifice, which is guarded by lower esophageal sphincter. It is right here, lower esophageal sphincter, and pyloric orifices is guarded by pyloric sphincter. This is present here. Now, one important point is, which you already know, we have discussed this before in gastroesophageal reflux disease. This lower esophageal sphincter is a physiological sphincter. There are no thick muscles present here, okay? So this is purely physiological. The pressure is determining this, orifice. What is the pressure in this area? Angulation of the esophagus, which is the intra-abdominal part of the esophagus, is also determining the function of lower esophageal sphincter. Then, what is the gastric emptying time is also determining that. So this is purely a physiological, whereas this is anatomical type of sphincter because the circular muscle is really thick here. Okay, so these are the important points. And this is greater curvature, and here is the lesser one. Now, what are the layers of the stomach? Just like any other parts of the GI tract, stomach also has got 4 layers. And these layers are mucosa, okay, submucosa, muscularis layer, and the serosa. So mucosa is the innermost one, followed by submucosa, then muscularis propria, or we can also call that, muscle layer, and then serosa. These are the 4 layers of the stomach. Now, among them, the mucosa has got a lot of function here. Okay, the mucosa of the stomach is thrown into different types of folds, which are called rugae or rugosities. And because of this rugae, we can identify stomach quite nicely. These are like a gross morphological features of the stomach. If you see the cut section of the stomach, the inner part at the lumen, the different mucosal folds can be seen, which are called rugae. This rugae increases the surface area of the stomach. Mucosa contains a lot of gastric glands which secrete gastric juice. Okay, that is the main secretion from the stomach. We'll talk about that during the function. And there are 3 layers of the muscle in the muscular coat. Can you tell me what are those 3 layers of the muscle? Yes?
The oblique muscle, the circular muscle, and the longitudinal muscle.
Exactly. It's absolutely right. Okay. The circular muscle, oblique muscle, and longitudinal muscle. So one extra layer of the muscle is there in the stomach, that is oblique muscle. Okay. And that's why stomach is a hugely distensible type of organ. Now see there, once again, this is the fundic part. Here is the lower end of the esophagus. Here is the pyloric end. Okay, these are different rugosities or rugae because stomach is cut open here, and these are the different layers of the stomach. The innermost layer, mucosa, then submucosa, muscle layer, and the serosa. Let's move on. Now, all of you, please focus on this picture which is shown in your screen. Look at these three layers of the muscle first. The circular muscle layer, okay, oblique muscle layer, and the longitudinal one. Oblique is the inner one, circular is the middle one, and longitudinal is the outer one, followed by serosa here. Okay, the inner two layer you already know. Innermost is mucosa and then submucosa. Now, this is called gastric gland. Okay, these are called gastric gland, which are present in the mucosa. These gastric glands are quite a long, tubular like glands. They are tubular type of glands there, and they have got different type of cells. They have got mucus cell, which are mainly responsible for the secretion of mucus in the stomach. And remember, mucus has got very, very important role to play. Mucus will not allow the digestion of the mucosa by the acid, means it is protecting the epithelium of the stomach mucosa by the acid digestion that is done by mucus. Another one, okay, are parietal cells and chief cells and G cell. So there are different types of cells present in the gastric glands. We'll talk about that. Now there is the mucosa. After that, it's submucosa here, and this is the muscle layer. See this oblique muscle layer is the innermost one, then circular muscle in the middle, and longitudinal the outer one, followed by serosa. So these are the four layers which are very nicely shown in this a histological picture. Now let's talk a little bit more about the structure of gastric gland, because this is really important from the physiological aspect. See here, each gland consists of mouth, neck, body, and base. You can see here. Okay, so mouth, neck, this whole area is body, and here is the base. They open into gastric pit. 3 to 7 glands open into one pit. So gastric pit means they are a depressed area, okay, in the stomach. So those pit, they collect the secretion, which is known as gastric juice. The epithelium of the gland is formed by different cell type. Some of the names I've just mentioned here. The important type of cells are called neck mucus cell, which are responsible for the secretion of mucus, which is clearly shown here. Okay, these are the mucus neck cell, which secretes mucus. Some other types of cells are also there, like surface mucus cells. Okay, they are also responsible for the secretion of mucus, but the more important one are called mucus neck cell. Second are stem cell. Okay, these stem cells are the undifferentiated cell which are situated in between the neck mucus cell, and they are responsible for the replacement if needed. Remember, these are epithelial cell. Epithelial cell can regenerate. So these are like a basal cell or a stem cell. If necessary, they can differentiate into different other type of cells. Now, third type of cells are called parietal cell. You can see clearly here. There are two functions of the parietal cell. One is hydrochloric acid secretion, and another is intrinsic factor. Every student knows this. I'm 100% sure every student knows this, because this is not a new information for you. And then chief cell. Okay, chief cell, this secrete pepsinogen and gastric lipase, but the most important is pepsinogen here. This pepsinogen will convert into pepsin under the effect of hydrochloric acid, and then this pepsin is responsible for the digestion of protein. And then at the base, stomach gland or gastric gland has called G cell. This G cell secretes gastrin. See that That's why the G shell it is named. So these are the different types of substances which are produced by the gastric gland. So you have already known about these things now. Axanthic cell or parietal cell. This axanthic is another synonymous term for parietal cell. Okay, they produce HCL and intrinsic factor. Okay, they are present mainly in the middle and upper region of the gland. Now, chief cell, also known as peptic or zymogenic cell. Now, they are most numerous type of cells, and they are mainly lying in the base of the gland, and their function is secretion of pepsinogen enzyme. And the G cells are present on the basal area, which secretes gastrin. So if somebody asks you what are the functions of the stomach, you can remember like these also. So the basic functions are secretion of hydrochloric acid, important one. Then secretion of intrinsic factor, secretion of pepsin, secretion of gastrin. Okay, these are all the different type of enzyme or hormones which are released by the stomach. Apart from them, stomach acts like a storage organ for the food. Whatever food we eat, it collects that food there. Food stays there for a few hours, and during that time there is a mixing of the food going on. It really helps in the digestion of the food. The larger food particle will be converted into the smaller one, and it really helps in the digestion. Now, after this, let's talk about the blood supply of stomach. So, what is the blood supply? Now, tell me which is the major artery that supplies stomach? Which is the major artery there? Yes.
Sir, the celiac trunk, basically.
Exactly. Absolutely right. It is celiac trunk. Celiac trunk is a direct branch of abdominal aorta. So celiac trunk, which is nicely shown here. Okay, celiac trunk. And this celiac trunk gives rise to different types of arteries. You can see here. Left gastric artery. See this? Okay. Left gastric artery, right gastric artery, then gastroduodenal artery. Okay. Then we have got splenic artery. This splenic artery also gives rise to a lot of branches like short gastric artery, left gastric epiploic artery, then gastroduodenal gives rise to right gastric epiploic artery. So ultimately, every type of arteries are connected with celiac trunk. Now see this. Stomach is supplied by branches of the celiac trunk, and celiac trunk is the artery for foregut. Means all the derivative which are derived from the foregut are supplied by celiac trunk. So these are the branches. It's a very important question from the exam point of view. We expect our students to answer this. So these are right and left gastric arteries, okay, which supply along the lesser curvature of the stomach. So this is the lesser curvature area. The second type of arteries are right and left gastroepiploic artery. Okay, right and left gastroepiploic arteries which supply along the greater curvature. So this is the greater curvature of the stomach. So you can see here is the right gastroepiploic. This is the left gastroepiploic. Short gastric arteries mainly supply the fundic area. These are the short gastric arteries which are directly arises from the splenic artery. Now apart from them, what are the venous drainage? Okay, ultimately everything is going back to the portal circulation. They're going back to the portal circulation. Now how? Just have a look here. Right and left gastric vein, they directly drain into the portal vein, whereas right gastroepiploic vein drains into the superior mesenteric vein, and left gastroepiploic vein drains into the splenic vein. Now, portal vein is formed by the combination of splenic vein and superior mesenteric vein. So ultimately, everything is going into the portal circulation. This is an important point here. But one other important point also you need to note, and you already know that before, there are certain anastomosis between the systemic vein and the portal vein into the lower end of the esophagus. These are tributaries of the left gastric vein, which are connected to the esophageal vein. So we call that a portosystemic anastomosis. And in case of portal hypertension, those veins are dilated and tortuous, and we call them esophageal varices. So these are some of the important points regarding blood supply of stomach. Now, what is the nerve supply of stomach? Remember, stomach is a visceral organ. So having said that, you already know autonomic nervous system is responsible for nerve supply of the stomach. Okay, all type of visceral organs are supplied by autonomic nervous system. So it has both parasympathetic and sympathetic nerve supply. Now, parasympathetic nerve supply comes from where? It is come from the vagus nerve. Vagus nerve. And when vagus nerve, is there, it is already divided into posterior vagal trunk and anterior vagal trunk. Okay, already above the stomach, when it's descending from the, in between the tracheoesophageal groove. Okay, or in the tracheoesophageal groove, we can say it is already divided there. So preganglionic fibers regarding the parasympathetic nerve supply are originated from, okay, posterior vagal trunk, and posterior vagal trunk is mainly, responsible for the right vagus nerve, whereas anterior vagal trunk is developed from the left one. Postganglionic neurons are very short and they lie directly within the wall of the stomach. This is the important point here. In parasympathetic nerve supply, the postganglionic neurons are quite short, and the ganglia are lying directly inside the organ. Whereas sympathetic, the preganglionic fiber arises mainly from the thoracic splanchnic nerve, okay, T6 to T10, and postganglionic arises in the ganglia of the celiac plexus. Now, this is the nerve supply of the stomach in the picture form. You can clearly see here the anterior vagal trunk is developed from the left vagus nerve. Posterior vagal trunk is developed from the right vagus nerve, and this gives rise to different branches in the stomach. See there, it is giving branches to different parts of the stomach. Okay, the main nerve which gives branches to the pyloric end is called nerve of Laterjet. Nerves of Laterjet. So this is an important nerve regarding the surgery of the stomach. If the nerve of Laterjet is divided, the pyloric end cannot function properly. Okay, so what happens if pyloric area cannot function properly, or if it loses its peristaltic movement after the nerve of Laterjet is divided, what will happen?
Sir, if there
Then
is
there
no
is difficulty
peristaltic
of moving
movement,
the
sir,
chyme forward.
Exactly.
food will retain in the stomach, sir, no push forward.
Exactly. The chyme, okay, which is the partially digested food, cannot go distally because of the lack of peristaltic movement. And we'll talk about that during the complication of surgery of the stomach. Okay, we call that, the different peristaltic movement disorder will be there because of the division of the nerve. So certain types of reconstructive surgery has to be done. So these are called Billroth 1 reconstruction, Billroth 2 reconstruction, Roux-en-Y reconstruction, and all those things. We'll come towards that during the management part, don't worry. So see there, the arrangement of this nerve almost looks like a crow's foot. Okay, so this can be important term here. There's no more meaning apart from the appearance here. Now let's quickly list what are the functions of the stomach. One of the important functions of the stomach is temporary storage of the food. Temporary storage of the food. For 2 to 3 hours, food is getting stored in the stomach. Stomach will churn that food out, mix that food, or divide the bigger food into a smaller particle, and that is done with the help of hydrochloric acid and the peristaltic movement of the stomach. mechanical breakdown and mixing of the food with gastric juice. That's what I'm just describing here. Some specific functions of the gastric juice are digestive function, protective function, and hemopoietic function. Now, regarding the digestive function, pepsin is one of the enzyme which is associated with protein digestion. Pepsin. In the beginning, it is present like a pepsinogen, which is an inactive type of enzyme. In the presence of hydrochloric acid, pepsinogen will be converted into pepsin. Now, that is the active one. Okay. Protective function is mainly done by HCl. So we are eating so many different types of food. Okay, drinks, food, and things like that. They may be contaminated with some of the bacteria. Now, hydrochloric acid will help us to kill those bacteria. Now, I'm going to talk about one of the very important function of this. But sometimes what happens, many people have, this habit, like if they develop some dyspeptic symptom, dyspepsia. Now, what is dyspepsia? Anybody? What is dyspepsia?
Sir, no production of HCL, sir.
Indigestion, basically.
Now, see that dyspepsia is a clinical term. Okay, you will study this in internal medicine side. It's a clinical term which is a mixture of the term regarding any abnormal, problem which is felt by the patient, like indigestion, any collection of gas in the tummy area or the stomach area, any type of pain there, okay, any belching, all of those are called dyspepsia. So this is very, very common in general population. So what habit they have? They think, oh, I'm suffering from gastritis, dyspeptic symptom. So let me take one antacid. Let me take a PPI or H2 receptor blocker. So even without proper indication, people are taking that type of drug very commonly, because in the developing world, like South Asian countries, or even in China or other type of countries, remember, you can buy medicine without any prescription. You can go to the pharmaceutical shop or medicine shop and ask for the medicine. They are happy to give that to you. So what will happen? People have this habit. So that means their hydrochloric acid is, isn't it, already decreased inside the stomach, or it is already diluted because of the intake of antacid. Now, on top of that, if the person is taking contaminated food and water, those bacteria which are present there cannot be killed by the hydrochloric acid. So there is a very high chance of GI tract infection as a result of this. One of the disorder which I want to mention here is typhoid fever, okay, which is caused by Salmonella typhi. So if somebody is not producing enough acid in the stomach, or if their acid is already diluted, then Salmonella typhi cannot be killed if it is present in the food or water, which can give rise to typhoid fever. So this point is important to understand. This is known as protective function. Hemopoietic function, intrinsic factor. Now, you all know intrinsic factor is absolutely necessary for the absorption of vitamin B12, and vitamin B12 is necessary for the synthesis of RBC in the bone marrow, especially the formation of DNA there. Okay, that's why it is known as hemopoietic function. Another function also I can mention here. Now, iron in the food is available in two different forms. One is called ferric form and another is called ferrous form. The ferric form of the iron will be converted into ferrous form of the iron in the stomach in the presence of hydrochloric acid, and then that ferrous form is absorbed. So this is also the function of the stomach. And ferrous type of iron is mainly present, in the animal type of food, whereas ferric form of the iron is mainly present in the plant sources. Remember, ferric has to be converted into ferrous first, and then only it can be absorbed. That's why we always tell to our patient, the animal sources of iron is much better than the plant source of the iron, because they are easily absorbed even without much struggle. Now, next function, Some substances are absorbed in the stomach, like water and alcohol. Okay, alcohol is an important substance which is directly absorbed from the stomach. So, if a person is having empty stomach, okay, and the person is drinking heavily in the empty stomach, the person can become drunk quite early. So these are some of the important functions. Let's move on. Now, another important, thing which I want to discuss here with you is how hydrochloric acid is secreted. Okay, how it is secreted by the parietal cells or oxyntic cell of the stomach. So this is the parietal cell. You can clearly see here, parietal cell, and there are the receptors. These are the three main receptors which are present there. One is called acetylcholine receptor. Okay, this is the muscarinic receptor, M for muscarinic. M3 type of receptors are present here, where acetylcholine will act. This is, H2 receptor, H2 receptor. So histamine will act here, and this is gastrin receptor, where gastrin will act. So M3 receptor for acetylcholine, H2 receptor for histamine, and gastrin, a G receptor for gastrin. Okay. Now this acetylcholine is secreted by vagus nerve, because this is a neurotransmitter for parasympathetic nervous system, and vagus nerve is the parasympathetic supply here. So stimulation of the parasympathetic nerve supply or vagus nerve will lead to excessive acid secretion. Remember that. Stimulation of H2 receptor, okay, will also give rise to excessive acid secretion, and stimulation of gastrin receptor also leads to excessive acid secretion. So these are the important stimulation for hydrochloric acid secretion. Let me repeat again: acetylcholine, histamine, and gastrin, they are all increasing the acid secretion. Now, how? This is the mechanism. Okay, so acetylcholine has calcium as the secondary messenger. Okay, this calcium will act on the protein kinase, and this protein kinase is responsible, remember, for the phosphorylation and then fusion of those vesicles. Okay, fusion of those vesicles, okay, or movement of the vesicles and all those things which are occurring inside the cell. Let's not go into the detail. These are a bit of depth. Actually, you don't need to know in that deeper sense. On the other hand, gastrin is one of the very important hormone there. This gastrin acts on enterochromaffin like cell. This is enterochromaffin like cell, and from there histamine will be released. So this is stimulated by the gastrin. It is also stimulated by acetylcholine actually, or the vagus nerve. So histamine will be released, and this histamine will act on the histamine receptor. So here ATP will be converted into cyclic AMP. Cyclic AMP is formed here, and the cyclic AMP will again act on the protein kinase. Okay, and so this acts like a secondary messenger here. Adenylate cyclase enzyme is responsible here. And G cell, okay, here gastrin acts, and this gastrin also involves the calcium as the second messenger, and this calcium is responsible for intracellular function. Now, the most important point is still not discussed. This is known as a proton pump. Okay, proton pump, also known as hydrogen potassium ATPase pump. Remember the drug proton pump inhibitor, they are directly blocking this pump. That's why they are the most powerful of the antipeptic drug we have. Okay, H2 receptor drug acts here. Antimuscarinic drug acts here. Okay, all of these are antipeptic drug, but the most powerful drug is here. This is proton pump inhibitor. Now, what is happening? See this. Okay, hydrogen is secreted into the stomach lumen. Okay, and then this is how the acid is secreted. Now, in detail, I'll explain this in another slide. See this? If you want to know this in a bit detail, it is nicely explained here. So please pay attention. This is a parietal cell. Here is acetylcholine receptor, here is a histamine receptor, and here is a gastrin receptor. These are the three main stimulation for the secretion of acid. Now, water will combine with carbon dioxide in the presence of carbonic anhydrase enzyme, and it is converted into the H2CO3. This is called carbonic acid. This carbonic acid will again dissociate into bicarbonate and hydrogen ion. This bicarbonate ion, okay, will be recycled into the blood. See this, it is going into the blood. Whereas this hydrogen ion, okay, with the help of proton pump, this is known as potassium hydrogen pump. This hydrogen ion is pumped into the lumen of the gastric pit. See here, okay, lots of hydrogen ions are here. Then see this potassium is also, is secreted here, but it is again recycled inside with the help of this hydrogen potassium ATPase pump. Energy is used for this, transport, and that's why it is known as ATPase pump. Okay, this is utilizing energy here. This chloride from the blood is taken into the parietal cell, and it is again, taken into the lumen. So this hydrogen and this chloride together is called hydrochloric acid. So this is how hydrochloric acid is synthesized and secreted. Now, another important, point you need to understand here is hydrochloric acid and pepsins are very powerful, substance there. Hydrochloric acid is acid. Acid, burns the, mucosa or the skin or any surface which comes in contact with it. And pepsin is a powerful enzyme. So what is there which is, protecting these things, okay, from the destruction? A highly alkaline mucus coat is there which is lining the stomach. So this is one of the very, very important protective mechanism. Rapid replacement of the epithelial cells. This is the, a normal, behavior of the epithelial cell, isn't it? It's a normal character of the epithelial cell. They can regenerate, they can replace quite faster. And then tight junctions which are present between the epithelial cell are also protective in nature. That's why we can withstand the highly acidic environment which is present in the stomach lumen. Means the underlying mucosal cells are not damaged by that acidic environment. So this is known as protection mechanism or self-protection from the damage of hydrochloric acid. Now, before we move further, what are the substances that inhibit the secretion of hydrochloric acid? Okay, what are the substances that inhibit? A variety of substances are capable of reducing gastric acid secretion when they are infused intravenously, like prostaglandin E2. Okay, prostaglandin E2. That's why when we give prostaglandin E2, in the treatment of peptic ulcer disease, it really helps. Analogs of prostaglandin known as misoprostol can be used for the treatment of peptic ulcer disease. It has got two functions. One, it is directly decreasing the production of hydrochloric acid, and another one, it is also stimulating the synthesis of mucus, and mucus coats, okay, that layer or ulcer, and really helps. Other several peptide hormones are there which will decreasing the acid secretion, like secretin, somatostatin, gastric inhibitory peptide, and glucagon. Okay, see this secretin, somatostatin, even CCK, cholecystokinin, glucagon, and gastric inhibitory peptide. All of these are inhibitory for the release or secretion of hydrochloric acid. So these are some of the important point, okay, you should understand. Now, somatostatin is an inhibitory hormone which inhibit almost everything, okay, whatever we can remember. In the pancreas also, remember, this somatostatin is an inhibitory one. Even in the GI tract, it inhibits the secretion of gastrin and histamine and appears to have a direct inhibitory effect on the parietal cell. So excessive somatostatin will cause a decreased amount of acid. Now, before we go for the break, one simple question I like to ask: what is that condition you call when hydrochloric acid is decreased in amount, or it is not synthesized or secreted at all? What medical term we use for that?
Achlorhydria.
Okay,
Regulatory
achlorhydria.
release.
Yes, achlorhydria and hypochlorhydria. Now, hypochlorhydria is a decreased amount of HCl, and achlorhydria is HCl is not synthesized at all or secreted at all. So these are the important terms. And in case of pernicious anemia, remember, which is damaging the parietal cells, achlorhydria along with lack of intrinsic factor occurs because parietal cells are damaged there, which is responsible for synthesis of HCl and intrinsic factor.